Hello, everyone. Welcome to today's symposium on solid tumors. My name is Ravindra Kolhe. I'm a pathologist at Medical College of Georgia at Augusta University, and I'm going to talk about our experience of using optical genome mapping on Saphyr for assessment of solid tumors, especially adult brain tumors, because that's our tumor of interest. These are my relevant disclosures. I'm employed at Medical College of Georgia at Augusta University, and these are some of my research support from industry. And most importantly, the opinions expressed during this presentation are my personal opinions and did not reflect or represent the opinions of any of my collaborators or employers. And the device or the instrument I'm going to talk on today, the Saphyr, is intended for molecular biology application, and this is not intended for diagnosis, prevention, or treatment of disease. This is my outline. In the next 20 minutes, I want to take you all on the journey for our experience of working with the Saphyr optical genome mapping on adult brain tumors. A little bit background about who we are. So my lab, I was recruited here 8 years ago to develop the molecular pathology program, and the lab which we have designed and developed is a CLIA lab, which is created by the state of Georgia for high complexity testing, and the faculty in my lab is mostly pathologists and doctoral scientists. In the last 8 years, we have put together a pretty solid molecular program, which encompasses most, if not all, the new technologies and platform we need for the new generation of molecular testing in a clinical setting. So if you look at our journey at cytogenetics movement to molecular cytogenetics, it was in 1988 we termed the chromosome, the term chromosome was coined. And as we moved away from this particular incident, then you can see the fish was added in 1986. The arrays were started, and we received the first FDA clearance for chromosomal microarray in 2014. And one of our plans going forward from movement of molecular cytogenetics to molecular cytogenomics is to work on newer technologies and platforms like optical genome mapping and see where and how we can incorporate that platform and technology in clinical care, especially both the constitutional as well as tumor types. Yesterday, I think you heard about the heme malignancies, and today we're going to focus mostly on how we can use optical genome mapping on solid tumors. So as we all know, Karyotype still is the gold standard for chromosome analysis, but it has its own challenges. It has a very low diagnostic yield. The other major challenge we have is a very long turnaround time for solid tumors for the culture of growth. It definitely misses the small changes, most commonly less than 5 megabase. We really need very special trained people in cytogenetics. I think that's becoming a major commodity now. And it is because it's a subjective method, it's prone to a human error. So with this background, I want to move to our journey of using optical genome mapping in solid tumors. Mostly, I'm going to focus on adult brain tumors because that's one of the most interesting tumors we have identified as one of the phenotypes we want to work on. So I'm a pathologist by training, so I have to bring in some H&E slides, even though this is a cytogenomics symposium. So adult brain tumors traditionally, for all these years and decades, have been classified into grades, grade 1 to 4. And this is how normal brain tissue would look like. And low-grade tumor and high-grade tumor, as you can see, mostly depending on the site as well as the cell type of origin. You can have a pilocytic astrocytoma, ganglioma, a pleomorphic xanthosarcoma, which probably will fit in your low-grade tumors. And on the high grades, you have the diffuse midline gliomas, the medulloblastomas, and primitive neuroendocrine tumors, which would come under the high-grade category. So this, again, was a very gold standard way of not only diagnosing adult brain tumors, but also for prognosis and therapy selection. Low grades, better prognosis; high grades, worse prognosis. But there was a paradigm shift in this understanding of these low-grade gliomas, especially based on the TCGA analysis in 2015. What we were able to identify that the diffuse low-grade glioma, especially the grade 2 and 3, we really need to look at the molecular analysis, especially the IDH1 mutation as well as 1p19q deletion. And based on these two main molecular abnormalities, this clinical presentation is very different. There is literally split survival based on these two tumors, irrespective of histologic subtype. And there are definitely additional molecular alterations do play a role in on top of 1p19q co-deletion along with IDH1 mutation in these low-grade diffuse glioma, especially grade 2 and 3 histologically. So the distinction, the clinical outcome was so significant that if you compare the molecular histological classification versus molecular classification, you can clearly see that a low-grade glioma with the IDH mutation and 1p19q deletion has a pretty split survival as compared to a glioblastoma with a wild-type IDH. So what dictates basically is not only your histologic subtype, but the presence of molecular dynamics in these tumors. And that has led us in the last 5 to 6 years to identify, on top of the histological subtypes, a lot of molecular information we would need to classify these tumors. So in summary, adult brain tumors are relatively easy to diagnose on histology as well as on biopsies. Not only diagnose, but also the grade. But based on the TCGA data, we have identified that especially the WHO grade 2 and 3 gliomas have a split survival, and this has led us to go into the molecular analysis of adult brain tumors for diagnosis as well as prognostications. So there are multiple papers which have been written in the past as well as been adapted. So we went through a whole bunch of published articles and their genomics on top of the TCGA data set, and we put together our own algorithm of looking at these tumors in the lab. This is what we clinically do on a daily basis using a SNP array to make that distinction of diagnosis as well as prognostication based on IDH1 mutation as well as 1p19q co-deletion, along with the whole variety of other genomic aberrations. So with that history in the background, I want to take you guys to our plan to look at these adult brain tumors which we have banked and see how optical genome mapping, number one, help us concordance with existing molecular data we have. And on top of that, what additional information would OGM would add to it, especially any clinically relevant information. So we are taking out 30 archived histologically diagnosed adult brain tumors from our tumor bank, and we want to make sure that all these tumors have known molecular testing done, especially the Oncoscan, which is a SNP array. On top of this, most if not all the tumors will have done P53 IHC, IDHR1 IHC, 1p19q deletion by FISH, EGFR amplification. So these are all fresh frozen tumors biopsies from the glioblastomas. Oncoscan has performed or will be performed on the exact same DNA on which we'll do the optical mapping. All the samples tested on the OGM were blinded to Oncoscan data, and the annotation was done based on the clinical SOP. Apart from other additional information that we had identified based on the evidence-based pathology as well as meta-analysis and the TCGA data, we had our initial investigation focused on clinically relevant genomic aberrations, which are very well established in the adult brain tumors. And this is just a few examples of them, which we want to make sure that we do identify the status of these aberrations in these brain tumors, which we have done. The solid tumor study sample prep is directly from the BioNano kit protocol. We used around 5 to 20 milligram of fresh frozen tissue for DNA isolation, and we used the BioNano Prep SP tissue DNA isolation kit in the lab for this particular study. The Saphyr workflow, if you are not aware of it, the key thing is isolation and characterization of high molecular weight DNA, labeling of that entire genome, transferring the labeled DNA to the cartridge, and then assembly and analysis of the genome. I want to take you through some of the really cool cases which we have investigated. This is probably the very early insight and an adult brain tumor, especially compared to Oncoscan. This is the case number one. This is an adult white male with a central glioblastoma. And here you can see that the slide shows a CNV profile by OGM compared to the SNP microarray. You can see the SNP on the bottom, Oncoscan, and the OGM on the top. The top panel is OGM data, and the bottom is microarray. Both the profiles shows the concordant aneuploidies and the CNVs, especially in chromosome 2, 6, 7, 10, 14, 19, and 22. I want to dive deeper in that data. And one of the major advantage of using an optical genome mapping technology is identification of an amazing discovery information, which is impossible on a karyotype or array, which is the fusion in. And this is probably the poster child case for looking at adult brain tumors on optical genome mapping, and we were able to identify a variety of complex translocation along with all the clinically critical genes, and in addition to that, a lot more clinically important genomes. So the circus plot basically shows you the copy number, the cytoband, and interstitial SVs, the translocation, and aneuploidy. And these are all the abnormalities which are absent in the BioNano control sample structural variant database, and this is how the pipeline works. And the first table I showed you earlier, the clinically important genes are highlighted in black. We want to make sure that we do definitely see some abnormality, yes or no, in those genes. And then I'll show you the genes that are unique to the BioNano database. So this is that earlier tables of what I showed you, which is expanded. We are going not only by chromosome, but also looking at the gene level to see if there is any CNVs, SVs, or complex abnormalities, and then comparing with our standard of care Oncoscan data. And this, and the red boxes are the ones which we have identified only in optical mapping, and the black boxes basically shows you the concordance with concordance of optical genome mapping with Oncoscan on case-by-case basis at a chromosomal and gene level. Continuing on the same case, Here, what we're trying to show is a mosaic homozygous deletion of CDKN2A. The circus plot on the top right shows chromosomes 7 and 9 with unbalanced translocation, which was indicated in the OGM, and the high resolution of the nested deletion, which you can see on the copy number profile with approximately 1.3 copy number state for that particular chromosome, that particular gene. And this is a result of unbalanced 7 to 9 translocation and an additional nested deletion. The unbalanced translocation is beyond the detection of SNP microarray because that's a major limitation. And as I said, not only we are able to get 100% concordance with the SNP microarrays, but on top of that, we are identifying a pretty significant clinically, potentially clinically relevant information, which was not there, and what was not there identified in earlier, even the TCGA database, because most, if not all, the TCGA database is done on Oncoscan. So looking at these tumors, we might be very interesting to go forward and compare that with the TCGA database. And continuing on the same sample or the same tumor, this is an MDM4 amplification, which is uniquely called by optical genome mapping. The chromosome 1q33, the MDM4 is amplified around 14 copies. And the circus plot here shows 14 copies of MDM1 amplification. And on top of that, there's a fusion with chromosome 2, 12, 16, and 17. I think this is another very interesting information which we have identified in this particular tumor. And the panel on the bottom shows multiple abnormal fusion of chromosome 1, which are involving in and around the MDM4 gene. We're still further investigating the clinical relevance and importance and even existence of these translocation, not only the brain tumors, but also other solid tumors. So this is a case number 2, which shows this shows a slide comparing the CNV profile by OGM to SNP microarray. The top panel is optical genome mapping, and the bottom is microarray. And both the profiles show concordant aneuploidies in chromosome 1, 4, 5, 7, 8, 10, 13, 14, 19, 20, 21, and 22. So even at the whole genome level, you can clearly see a distinct concordance with overall whole genome abnormalities in these two different platforms. So on top of the concordance, we are able to identify a huge amount of additional information in the form of CNVs, SVs, as well as fusion and translocation in this particular tumor type. The blue arrow shows evidence of Chromothripsis of Chromosome 8, which is beyond the detection capabilities of SNP microarray, and the bolded genes are the ones which we which are critical or clinically important in the TCGA database, which we use for regular clinical reporting. And as you can see, the comparison of Oncoscan data along with optical genome mapping, which highlights the unique things which we have identified by optical genome mapping and the concordance in the black boxes. So here we can look at the complex chromothripsis, which was identified in the chromosome 8 in the optical genome mapping, a large intrachromosomal translocation with MYC and multiple maps with FGFR1 gene, spanning in the FGFR1 gene. Continuing on the same case, the Chromothripsis on chromosome 8, which is easily visualized in the circus plot, And then both the optical mapping and Oncoscan shows aberrations on the chromosome 8, while the optical genome mapping highlight complexities around the chromosome 8, especially many copy number breakpoints with fusion breakpoints, and actionable genes are MYC as well as FGFR1 in that region. Continuing on the same case, we also identified the RB1 deletion on the background of chromosome 13 loss, where there's a complete loss of function of RB1 gene, and the deletion coordinates very clearly identified along with the size. The next case, this is again a adult brain tumor, female, 43 years old, which shows the concordance for Oncoscan and whole genome mapping. The slide shows the CNV profile. The top panel is the OGM data, and the bottom is a SNP microarray, and both the profile shows concordant aneuploidies in 1q deletion, 7, 10, 11, 13, 14, 15, 19, 21, and Y chromosome abnormalities. Again, coming back to the strength of optical genome mapping, on top of the concordance aneuploidies, we definitely have a huge amount of structural variants, CNVs, and fusions. And then, as you can see, the amount of information we can capture on OGM is significantly higher than what we are currently able to do it on a SNP microarray / Oncoscan. Here, as you can see, the majority of the concordance is with optical genome mapping with 100% clinically relevant loci. Here we also see in this case the Chromothripsis of chromosome 18, and along with additional genomic aberrations seen on chromosome 18, there are multiple SVs which we can see on the chromosome 18. Even though SNP microarrays also shows aberration, the OGM provides better characterization of these aberrations. Here you can see the log ratio along with OGM. Another case, again, this is an adult brain tumor. This is a male, 62 years old. Here, showing the CNV profile by OGM compared to SNP. The top panel is OGM, the bottom panel is SNP, and both the profiles show concordant aneuploidies in 1, 7, 10, and 11. And here, the circus plot shows CNVs and SVs. And again, all the genes which are clinically relevant are highlighted based on TCGA. So not only we are capturing everything we need clinically relevant, but on top of that, we are capturing additional information which has a potential to be clinically significant. Again, 100% concordance with a SNP microarray and OGM in this particular case. And we identified chromosome 10 aneuploidy and partial deletion of PTEN, which are also called by the SNP. But in OGM, the CNV track on the top shows chromosome 10 loss, and in a high resolution of nested deletion, which you can see on the copy number profile with approximately a copy number state of 1.2, surrounding copy number state of approximately 0. So you can clearly see the copy number profile in an OGM as compared to a SNP microarray at a gene level. Moving on to the next case, again, this is an adult brain tumors, 58-year-old female. Here it shows the comparison between OGM and SNP, OGM on the top, SNP on the bottom. Both the profiles show concordance aneuploidies in 2, 7, 10, 11, 19, 20, and X. Again, I'm repeating the story case after case, but just to bring a point to each and every one that not only we are having a concordance with what we are able to see on the SNP microarrays, but On top of that, there is a significant additional information OGM adds to the knowledge base in these adult brain tumors. So the same thing here. Here we are highlighting one of the region on chromosome 7, which basically shown multiple aberrations on chromosome 7 with multiple structural variants, as you can see here on the circus plot. Even though SNP microarray has limitations in showing, the OGM actually better characterize these SVs, including meta amplification, and you can see you can go up to 21, 40, and 21 copies in that particular region of MET. And this information at this granular level definitely helps you to make clinical relevant decisions. So then I would like to put together our summary and conclusions, which we have identified in our initial aspect of validation. So bottom line, there's 100% concordance on all these adult brain tumors which we have seen, and the data compared by OGM versus array, especially the SVs and CNVs. In conclusion, the karyotype FISH and chromosome microarrays are recommended tests globally for routine diagnostic tests for diagnosis, as well as prognostication of adult brain tumors. In our study, in initial data, we have shown there's 100% concordance of optical genome mapping versus SNP microarrays. But what I think the importance of optical genome mapping is that it's potential to identify unique genomic abnormalities and also better characterize the structural variants, which are at a very high resolution and at granular level. I think it's a great tool for discovery of these novel aberrations, especially the structural variants and fusions in adult brain tumors, which I think were limited in the TCGA data because of the platforms which were used. It is a great tool to assess overall genomic instability and abnormality, especially the prognostication, especially its use in prognostication theranostics. And I think it might have, it has a potential to gauge the therapy response, very similar to TMB in immune therapy. The optical genome mapping in our study detected multiple clinically relevant actionable SVs events which were missed by SNP microarrays. On top of that, the OGM provided better characterization of chemotherapeutic events. Again, that goes into the earlier discussion on looking at overall genomic instabilities and abnormalities at the tumor level or the whole genome level. So in summary, this data set is our path to develop a lab-developed test on OGM for solid tumor application. And this is based on our experience of using SNP microarrays. And currently that's what we're using. And I think if this journey continues with the bigger data set and the concordance stays at this level, I think we definitely have a chance to adapt optical genome mapping as a true alternative for assessment of adult brain tumors based on the WHO guidelines. And there are, I think, at least three major advantages. One is reduced hands-on time for OGM as compared to conventional methods, especially SNP arrays or karyotype, a faster turnaround time, again, as compared to karyotype, and is definitely cost-effective per sample base, again, as compared to a FISH, karyotype, or microarray. So overall, our initial experience with optical genome mapping in solid tumors has been phenomenal. We're continuing this journey, and we're looking for collaborators and additional partners to put together this This analysis of optical genome mapping in solid tumors, especially focused on adult brain tumors. I would like to thank Dr. Nikhil Sirjpal, Ashish Mundala, and Dr. Amin Rojani in my lab and in the institute, and by Nano, Dr. Ben Clifford, Dr. Andy Pang, Dr. Alex Hasty, and Dr. Alka Chobe. Thank you.